Max Super Specialty Hospital, Saket, and he is fond of bariatric anesthesia as well as airway and regional anesthesia, and he's going to speak on very important topic which has gained all the more importance after COVID. So everybody is using it left and right. So Dr. Abhishek Sharma will be speaking on non-invasive ventilation. Dr. Abhishek, please.
Respected chairpersons, organizers, dear students. Now we'll discuss about non-invasive ventilation. By definition, non-invasive ventilation refers to the administration of ventilatory support without using an invasive artificial airway. Broadly, there are three modalities through which NIV can be administered, that is negative pressure, positive pressure, and high frequency nasal oxygenation. The last topic has been taken in an earlier lecture. This discussion will be mostly about positive pressure. The earliest, a little bit about the history in brief, the earliest non-invasive ventilators that were developed were negative pressure ventilators and were mostly used for neurological disorders like post-polio paralysis or drowning victims. Two main types of ventilators were developed. The tank type ventilator, also called as iron lung, and the body jacket ventilators. Now, these work on the principle of generating cyclical negative pressure around the body or the chest and thereby drawing air into the lungs. And expiration was usually passive. The earliest negative ventilators were developed in the 1800s, and the device named Sparrowford, which is developed by Dr. Wallis, was made in sizable numbers. Graham Bell also chipped in with a body jacket type of ventilator. It was Drinker and Shaw who first measured negative pressure ventilator on a large scale, which was perfected by Emerson. The Emerson ventilators were used in large scale during the polio pandemic. This picture is of Paul Alexander, who is a post-polio survivor and is seen using the Emerson type of ventilator in 2020. However, NIV was not found to be very successful for acute respiratory failure. And in the 1960s onwards, there was increased use of invasive ventilation for acute respiratory failure. It was in 1980s, there was a re-emergence of NIV with increased use of CPAP devices for obstructive sleep apnea. And in the last 2 to 3 decades, there has been an increased use of non-invasive ventilation for various indications. And as the technology has progressed, newer modes of NIV has been developed. The indications for NIV can be broadly divided into 3: to treat respiratory failure, to prevent tracheal reintubation, and to facilitate weaning from mechanical ventilation. Again, respiratory failure indications can be divided into acute and chronic. Acute failure can be of type 1 or type 2, type 1 being characterized by hypoxemia, mostly due to the ventilation-perfusion mismatch, and type 2 respiratory is characterized by hypercapnia with failure to ventilate. Obstructive sleep apnea and obesity hyperventilation syndrome are one of the most chronic indications of NIV. It is also used in patients with stable COPD and other neurological disorders. Now, coming to certain evidence-based indications as per the American Society and European Respiratory Society guidelines. The strongest evidence for benefit of NIV is in acute exacerbation of COPD. Now, bilevel non-invasive ventilation is considered highly beneficial in case of respiratory acidosis due to COPD. And it has also been used can be used as a trial in patients who require endotracheal intubation and mechanical ventilation. Now, it is shown to reduce the sensation of dyspnea and also the need for immediate intubation in these patients. And also there is reduction in both respiratory and non-respiratory infections. Similarly, there is a strong indication of NIV in acute respiratory failure to cardiogenic pulmonary edema, and also in respiratory failure in immunocompromised patients. So bilevel NIV and CPAP is both are indicated in cardiogenic pulmonary edema. NIV is also found to be beneficial in post-operative patients who have undergone supradiaphragmatic abdominal surgeries. And there is a reduced need for tracheal reintubation, and there is decreased atelectasis in these patients, and also reduced nosocomial infections. It is also indicated in respiratory failure in patients with chest trauma. It decreases the symptoms in these patients, and also there is decreased need of intubation in these patients. Patients who develop terminally ill patients receiving palliative care who develop respiratory failure are also candidates for non-invasive ventilation. It is also used to wean patients of mechanical ventilations in patients who develop hypercapnic respiratory failure. So there is reduced need for reintubations, ICU stays, and incidence of nosocomial pneumonia. It is also used to is indicated to prevent post-extubation respiratory failure in high-risk patients, like, for example, COPD patients. During the COVID pandemic, World Health Organization also introduced guidelines for non-invasive ventilation. It is indicated in patients in whom emergency signs have been eliminated, and both CPAP, high flow nasal oxygenation, and BiPAP, all three were indicated in COVID patients. Coming to contraindications, there are certain absolute contraindications like cardiorespiratory arrest, anatomical abnormality, or inability to keep the airway patent, for example, in patients with fixed airway obstruction or severe facial trauma. Patients with severe hemodynamic instability are also not candidates for NIV. And of course, patient refusal. There are certain relative contraindications also, like uncontrolled vomiting, uncontrolled agitation, or altered mental status, copious secretions, or in which or conditions in which patients is not able to expectorate increased amounts of respiratory secretions. Untrained pneumothorax also has to be treated first before initiating NIV. Now, relative condition also includes recent, not all upper GI surgeries, but certain surgeries in which there is high chances of anastomotic failure, upper GI surgeries. So once we have a patient indicated for non-invasive ventilation, we have to rule out the contraindications for NIV and initiate NIV as early as possible to prevent further deterioration. Coming to evaluation of patients who are indicated or who are undergoing non-invasive ventilation. Clinical parameters like consciousness and sensorium are important in these patients, and there can be, if the patient is not is an altered sensorium or is not conscious or not able to follow commands, and it may be a contraindication for NIV. Airway has to be assessed before beginning non-invasive ventilation, and any fixed obstruction or any facial deformity can be a contraindication. And also, if it's a difficult airway and if the patient needs intubation, then the difficult airway card should be kept ready. Hemodynamic monitoring, heart rate, blood pressure, respiratory rate, and signs of dyspnea, saturation are important parameters both at the beginning and during monitoring during non-invasive ventilation. Arterial blood gases form a very important part of for monitoring for non-invasive ventilation, and the success or failure of NIV can be monitored by arterial blood gas. ETCOs, if available, can also be very helpful. Cardiac parameters like ECG and echocardiogram are important in patients with COPD and also in cardiogenic pulmonary edema for monitoring any cardiac arrhythmias like atrial fibrillation, which is common in these patients, and also in cardiogenic pulmonary edema for assessing ventricular both right and left ventricular function. Radiological examination, chest X-ray, if it's available, it's better, so that especially in chest trauma patients and COPD patients, can rule out pneumothorax. Chest CT may be needed if indicated, if time permits. Ventilative parameters like tidal volume. Today's modern ventilators, even portable ventilators, do monitor, do indicate tidal volume, and it has to be monitored in assessing the success of ventilation. And it also we have to also monitor leaks. Patient comfort and tolerance is one of the most simplest and also an important parameter for assessing ventilator patient synchrony. For chronic therapies like OSA, polysomnography, and oximetry are also indicated. Now, a newer modality called the integrated pulmonary index, which has been introduced, and several studies have shown promising results of this monitoring in patients for respiratory monitoring using this index. It consists of 4 parameters algorithm based on heart rate, SpO2, EtCO2, and respiratory rate. Now, based on these parameters, once we initiate NIV in patients for acute failure, the response within 1 to 2 hours is important. And the success and failure may depend in the first few hours of initiating NIV in a patient with acute respiratory failure. A comfortable patient with good ventilator synchrony, improvement in dyspnea, correction of blood gases, hypoxia, improvement in PaCO2 is usually indicative of success of NIV. Signs of failure should be immediately be identified and are usually indicated by worsening level of consciousness, poor hemodynamic instability, or worsening ventilative parameters, low tidal volume, patient going into respiratory arrest, or worsening blood gases. Severe hypoxemia is generally after initiating NIV in the first 2 hours is an indication for intubation in this patient. So once the patient is on an NIV, patient should be monitored closely the first 2 to 4 hours. And if there are signs of failure of NIV, patient should be intubated immediately. Now, the goals of non-invasive ventilation, short-term goals, are similar to those of invasive ventilation. And they include reduced work of breathing, unloading of respiratory muscles, improving or stabilizing the gas exchange, and relieving symptoms of the patient. Long-term goals for chronic therapy like OSA include improved sleep duration and to maximize the quality of life and enhance the functional status of the patient. So, from this discussion, the advantages we can infer over invasive ventilation is that it avoids intubation and its complications, and it also obviates the needs for sedation and also neuromuscular paralysis, which is usually needed for invasive ventilation. And it also allows the patient to communicate and also have a meal intermittently. And it also avoids the risk of ventilator-associated pneumonia associated with intubations. Now, before we discuss about the equipment, we should discuss about the 2 basic differences between invasive and non-invasive ventilation. The first is the non-hermetic nature of non-invasive ventilation, which means that the entire system and the patient is not a perfectly sealed system. And there are certain intentional and unintentional leaks in the system, which can affect the triggering. If there is too much of leak, it can stimulate the ventilator triggering, and also the cycling and volume delivery, and also the monitoring of the various parameters like tidal volume. Also, because the interface in this case is the patient's upper airway, so the ventilator lung assembly cannot be considered a single compartment model because of the variable resistance of the upper airway. Thereby, there is an ineffective delivery of the tidal volume. So, the ventilation device for non-invasive ventilation needs to compensate for leaks. It has to be configured for modes and alarms. And also, many of these portable systems usually have to be configured for single limb circuit. Now, coming to nasal masks, this is one of the most simplest and the most patient compatible masks. They interfere least with patients' speech, eating, and also lost cough. They're also less danger of aspiration due to vomiting. Claustrophobia is also uncommon with nasal masks. However, if the patient is unable to breathe through the nose, for example, due to blocked nasal passages, or there's a lot of mouth breathing, like in acute respiratory failure, where there is both naso-oral breathing, it cannot be used in such situations. Also, in edentulous patient or in sleep when the patient is a mouth breather. So in most cases, oronasal mask is used for acute respiratory insufficiency. This is the most common mask which is used. And it is also better in edentulous patients, and generally is more effective ventilation is possible with this. However, the disadvantages include it is claustrophobic, and if there is vomiting, there is a risk of aspiration, and then it hinders with speaking and coughing. Full face mask also almost has similar advantages, features as oronasal mask, but it may be preferred in a patient with nasal sore or deformity, and it has a larger dead space compared to oronasal mask. Okay, the helmet is a device which can be used for long duration non-invasive ventilation, and also in cases of major air leaks, edentulous patients, and mask intolerance. Now, it also consists of a seal which is made possible by a collar on the shoulder and the underarm straps which seals the mask. It has an inspiratory limb and an expiratory limb. There is also a port for feeding through a nasogastric tube or a tube like a straw, something which the patient can use to drink liquids from. So, but it really needs a high flow during a continuous CPAP, more than 40 liters per minute. And during pressure support ventilation, higher PEEP and pressure support level, more than 50% higher than those needed by a face mask is required. And we use maximum pressurized rate. That is, rise rate is very short. So the advantages are that it's usually more compatible compared to the other oronasal mask, and nutrition hydration is also possible. And there is no facial skin lesions with this. However, there's a large dead space in this, and there's a high chance of CO2 rebreathing in this. With this, there's also claustrophobia, and also it cannot be used in a tetraplegic patient also. Now, before we use a mask, there are certain templates available which usually come with the mask, which identify the correct size of the mask, and these should be used to identify the correct size of the mask which is to be used. Coming to circuits, the most common circuits that is used with a portable NIV ventilator is a single limb circuit. So a single limb circuit consists of a single tube and which has a leak at the patient end. In such a situation, a non-vented mask is used. However, if a vented mask is used, there is no leak in the proximal limb. So the leak can be present either in the proximal, in the patient end of the circuit, or on the mask. Another single limb circuit has a pressurization line running parallel to the circuit, and it has an active exhalation valve which is controlled by the pressurization line. The pressurization line also keeps the circuit pressurized. It is also used with a non-vented mask. The dual limb circuit is commonly used with a critical care ventilator, and it has a separate inspiratory and expiratory limb. Again, a non-vented mask is used with this circuit. Now, in single limb circuits, oxygen can be added by a adapter which has a side port for oxygen tubing, and also oxygen can be connected to one of the expiratory vent ports in the mask. Make sure that the other vent port or in the proximal limb of the circuit vent port is open in such a situation. Humidification can be achieved by separate humidifiers which can be detached from the ventilator. This usually comes as a separate unit with the ventilator and should be compatible with that particular ventilator. We can also add a HME filter, which can be attached to the patient end. This is the ideal position, but it makes the circuit quite bulky. You can also add bacterial filters or HME filters. So make sure in case of bacterial filter, you want to prevent the contamination of the ambient air, the leak should be away from towards the ventilator, and the HME filter should be towards the patient. And in such a situation, a non-vented mask is used. So a low resistance bacterial filter should be used. And if you want to prevent the contamination in the ventilator, then a separate bacterial filter can be added at the ventilator port. It can affect the triggering and pressurization. So a low resistance filter should be used. Now, ventilators can be broadly classified into portable or critical care ventilators. So the portable ventilator or the home non-invasive ventilator, they're usually configured for a single limb circuit. And in these circuits, there is potential for rebreathing with high minute volumes. And oxygen in these systems, as you have seen, can be added, and they usually have an anti-excitation valve. Now, these devices are driven by internal pressure source. Now, critical care ventilators use a dual limb circuit. Some have provision for both, and ideally they have to be used with a dedicated NIV mode on the ventilator, which configures for the leaks, and sometimes also has provision for single limb circuit also. The advantage also is that you can provide a measured oxygen supplementation to the patient. Now, these ventilators are supplied by compressed gas and usually can achieve high flow volumes. Now, having said that, with improved technology, there are intermediate ventilators where you can get features of both portable and critical care ventilators. We proceed to discuss the modes of non-invasive ventilation, the basic modes. There are certain terminologies which need to be discussed. There are a lot of confusing terminology. Now, BPAP generally means bilevel positive airway pressure and consists of IPAP and EPAP, which is expiratory and inspiratory positive air pressure. Now, BiPAP with a small I is actually a brand of the Philips portable NIV device model, which has a S mode similar to BPAP and a ST mode similar to BPAP mode with a backup rate. And BiPAP with a capital I is a registered trademark of a dragger ventilator, which is actually mostly used for invasive ventilation. Now, coming to the modes. So before discuss the modes, we'll quickly go through about the pressure time or the ventilatory cycle and the main settings which are used in non-invasive ventilation. Now, in circle A, we can see is the pressure trigger, which can be a pressure or a flow trigger, right? So we can adjust the trigger sensitivity on the ventilator. The rise time is the time which is taken to reach the IPAP, which is the inspiratory pressure, and the circle D here shows the cycling time or the inspiratory time when the cycle changes from inspiration to expiration. So again, we can also adjust the inspiratory time in certain modes and ventilators. And the pressure which falls at expiration, at which the expiration ends, is the CPAP and the EPAP pressures. Now, a characteristic of the NIV ventilators or patients who are kept on NIV are that patients always has a spontaneous effort. Some spontaneous effort is present, and most of these ventilators and these modes are pressure targeted ventilation. Now, rise time is the time taken to reach the target inspiratory pressure, and devices usually have settings from 1 to 5, which indicate a range from 100 to 900 milliseconds approximately. It can differ between ventilators. So a short rise time means that a higher peak inspiratory flow is reached and there is lower workup breathing. So you set a short rise time in acute insufficiency. If, for example, in COPD patients, longer rise time is usually kept in restricted lung disease and in slower respiratory rates. Ramp time is usually used with a CPAP mode, and it is a time during which pressure increases from the lower starting pressure to a set therapy pressure. So you can set a lower pressure and you can set a ramp time, and the final set CPAP pressure gradually increases over the set time. So it acclimatizes the patient requiring high treatment pressures, and it varies from 5 to 45 minutes in various devices. Now again, ramp time is usually switched off in BPAP mode, or it's rarely used with BPAP mode or in severe respiratory insufficiency. Now again, ventilator triggers are usually set on various devices 1 to 5 or 1 to 10, depends on the device. Now as the numbers increase, it decreases the trigger sensitivity. That means the patient needs increased effort to trigger an inspiration. So pressure trigger was used in older NIV models, and in newer models volume trigger is used, and it has a faster response. The delay in initiating inspiration is less, so it is faster. Cycling again is usually flow or time cycle. The flow cycle usually happens during patient trigger system. So the flow increases till the pressure reaches to IPAP, and then it falls to CPAP or EPAP pressure in spontaneous breath. Time cycle is usually ventilator triggered, and you set the time for inspiration, and when the time ends, the expiration cycle starts. So it is set during for backup breaths. Now quick discussion about pressure target ventilators. Now these pressure target ventilators are were usually used, and they set a fixed pressure, and the tidal volume may vary according to the pressure attained and leaks, etc. So the peak airway pressure is limited, and it is useful in patients with risk of pyrotrauma, and there is good leak compensation in pressure target ventilators. However, there is no tidal volume guarantee with pressure targeted ventilators. Modern ventilators also have modalities of both. So pressure targeted ventilators ventilation may not be able to provide adequate volume or keep up with high minute ventilation. Now two basic modes that we are going to discuss are the CPAP and the BiPAP mode. The CPAP mode, basically there is a net positive pressure in the airway. A CPAP is set, and the inspiration and expiration, the positive pressure is maintained during the entire cycle. In BiPAP mode, an inspiratory pressure is added. So from the set EPAP pressure, when the patient breath triggers, the pressure rises to IPAP, the flow increases till the inspiratory pressure is reached, which is flow cycled, and then it comes down back to the CPAP level. Now the difference between the IPAP and EPAP is the pressure support, and this addition of IPAP generates a tidal volume. So CPAP mode is not actually a ventilation mode, strictly speaking, and a constant pressure is delivered throughout. What you set on the machine is CPAP, the ramp time, and the start pressure. The respiratory flow rate and tidal volume is entirely dependent on the patient. So it is indicated in hypoxemia, type 1 respiratory failure, acute cardiogenic pulmonary edema, and obstructive sleep apnea. Now how it mainly acts is it reduces upper airway collapse, and it improves the VQ mismatch by keeping the alveoli distended and reducing the interstitial edema. So it reduces atelectasis and also improves the functional residual capacity, and it also counters auto PEEP in COPD patients and reduces preload and afterload. Now, BiPAP is similar to a pressure support ventilation mode, but you must keep in mind that when you are setting for a pressure support ventilation, pressure support and PEEP will add to a peak pressure of 15. When you're setting for an inspiratory positive airway pressure, the IPAP, set IPAP is the peak pressure in a NIV ventilator. So for a BiPAP, you have to set the inspiratory pressure, the expiratory pressure, the trigger sensitivity, and the rise time. The inspiratory trigger, the trigger for the inspiration, the breath rate, and the cycle length for inspiration is dictated by the patient's effort. Now it is indicated in type 2 hypercapnic respiratory failure where ventilation is needed, where there is a ventilation failure, and also in obesity hypoventilation syndrome. Now, again you can see in this graph that the ventilator in CPAP continues to give a positive pressure throughout, and the respiratory flow, it depends on the patient's effort. Once there is no patient effort, there will be apnea. Similarly, in BiPAP also, the patient triggers each inspiratory effort, and inspiratory effort is flow cycle till the pressure is reached. And again, if there is no trigger, there will be apnea in this patient. So there is a ST mode, which is commonly found in a Philips ventilator, or the assist control mode, which is found in other ventilators, where you can set up a backup respiratory rate, where the ventilator triggers breath when spontaneous rate falls below the preset rate. So you can see here, if the patient does not trigger the inspiration and the respiratory rate falls below the backup rate, the ventilator kicks in and triggers a breath. Now here you also have to select the inspiratory time, or the TI. So in case of a ventilator breath, the inspiration is timed. Here you can see for a manual breath, for the patient effort, the inspiratory cycle is flow cycled, and in case of a ventilator trigger breath, the cycle is time cycled. With even more control, there is a T mode or a control mode, which is similar to a pressure controlled CMV mode during invasive, almost similar to that. There is the clinician presets the ventilator control breathing cycle. So you set the entire respiratory rate, the IS/V ratio, or the expiratory or inspiratory duration, and the ventilator delivers the breath regardless of the patient's effort. So even if there is a patient's effort, the ventilator will not support that breath, and it is continue to give the breath according to the set rate and the set parameters. So it is used for patients with a very weak inspiratory effort, muscle strength, or inadequate inspiratory time. We have seen these both modes are pressure targeted modes. So in these modes, in the pressure target ventilation, we have seen that the tidal volume of the minute ventilation is varies, and it's not it may be inadequate in high volume situations or in patients with severe respiratory and chronic insufficiency state. So there are certain advanced modes like the AVAPS, the average volume assured pressure support, or the intelligent volume assured pressure support, which is given by Philips and ResMed respectively. Now in both these modes, you can set the target tidal volume or the minute ventilation. Both are hybrid pressure volume modes. So what happens is that we can set the target tidal volume in these modes, the respiratory rate, and the EPAP, and the inspiratory time. And the pressure support here will vary to meet the set target tidal volume or the minute ventilation. Now they are generally not used for acutely decompensated states, because the ventilator in this case studies the patient's ventilatory cycles for some time, and then changes the pressure support required to meet the minute ventilation. So it is used mostly for patients recovering from acute states, like patients who are recovering from acute COPD or chronic respiratory insufficiency due to neuromuscular diseases or OHS. Now, we'll quickly look into the initial settings. These are just suggested settings. So we start with the IPAP or EPAP setting of 10 or 5. We target a tidal volume, we achieve a tidal volume of 5 to 7 ml per kg. You can increase IPAP and also EPAP to achieve this target. You have to do this manually. And subsequent adjustments you have to make by monitoring the patient. If there is persistent hypercapnia, you increase IPAP by 2 centimeters of water. And if there is persistent hypoxemia, you can increase EPAP or even IPAP by 2 centimeters of water. But IPAP generally should not be more than 20 to 25 to avoid gastric distension. And maximal EPAP should be 10 to 15. Also, a CPAP of the beginning CPAP should be not less than 5 or 6. In cases in which you have high risk of airway collapse, you use a higher EPAP of about 7. So if we are keeping a backup respiratory rate, initially should be 10 to 16 per minute. And if available, FiO2 of 1 should be kept. And then adjusted according to the SpO2. Now, we'll quickly see a video of how to initiate NIV.
Now we will be demonstrating the initiation of non-invasive ventilation therapy. For this demonstration, we have our staff nurse, Sister Sadia, our technician, Mr. Dinesh. And so we have our portable non-invasive ventilator, a single limb tube here for as a conduit. This tube has a port for oxygen supplementation at the patient end. We have an oronasal mask, which has the expiration leaking ports and the harness for this mask. First, we power on the machine and we go to the menu settings. This, we are going to provide the CPAP therapy to this patient. So we select the mode at CPAP. The CPAP pressure of 12 centimeter of water is selected. The ramp length here is selected at 5 minutes and with the starting pressure of 6 centimeters of water. And initiate the therapy for this patient after fitting the mask. So we first, in our institute, in our department, this is the way we put the harness on the patient. We first place the harness behind the head of the patient and we place the mask on the patient. And then you just put in the straps. It is important that we do not tighten the straps completely at this particular moment and just leave it loose. So this mask is very loose right now. Then we initiate the therapy and we gradually push the mask onto the patient so that the patient does not feel any discomfort or claustrophobic initially and doesn't feel the blast of air coming from the machine. Once the patient is comfortable, we finally tighten the mask around the patient. And then we check the leaks. If there is any extra leak around the edges of the mask with our hands.
So coming to certain problems and troubleshooting. Initially, if you put the mask and the patient complains of too much pressure or breaths are coming too fast, then there could be possible auto-triggering or high IPAP. So in this situation, you decrease the inspiratory pressure or increase the rise time or both, or reduce the backup rate if it is too high, or decrease the trigger sensitivity, and make sure that leak ports are not blocked in a single limb circuit. You can also acclimatize the patient and loosen the harness, encourage patient to hold the mask himself or herself and gradually then tighten the mask. In cases where the patient complains of air hunger and tells that he's not getting enough air, then probably not enough tidal volume is being generated or not enough air is going in. So to check for leaks or increase the inspiratory pressure and reduce the rise time if it is too high, and increase the trigger sensitivity. And it is also good to auscultate and assess for breath sounds for severe bronchospasm or if you're suspecting pneumothorax also. Air leak, again, air leak is a common problem, and in this situation, check for the mask, check for a loose harness, and encourage mouth closure. If using a oronasal mask, you change you can change for a oronasal mask. If patient complains of claustrophobia or discomfort, check the fit, check the straps, and you can also consider sedation if the patient is agitated. Pressure sores are also common, especially with nasal and oronasal masks. So in this case, you use a gel padded mask and check for a damaged mask seal. And also you can consider application of intermittent NIV and schedule breaks if possible. Also cover the vulnerable areas with protective dressing. In case of nasal congestion, you can use nasal steroids or add decongestant antihistamines. And for eye irritation, again check the mask fit. Maybe the air is leaking from the upper portion and into the eyes. For dry mouth is also common in patients with extended use of NIV, and you can provide humidification or daily oral care and use nasal saline or emollients. There are certain oral sprays which are also available, which contain material similar to a artificial tears, methyl tears, and sprays are also available, which you can spray on the lips and the oral mucosa. Gastric distension also is although uncommon, but it can happen if too high pressures are used. Nasogastric tubes are generally sometimes worsen the leak from the mask and may actually increase the reflux because if it passes through the lower esophagus sphincter. For hypotension, again, consider reducing pressures. If you suspect a pneumothorax or if you diagnose a pneumothorax, it is always advisable to immediately stop the ventilation. If the patient is in distress, then reduce the pressures, and a thoracotomy tube should be placed as soon as possible. That's all for now. Thank you so much.
Thank you, Dr. Abhishek.
Thank you, ma'am.
I think question answers are at the end of the session, and we are already, behind time. So I'll invite our next speaker, Dr. Kanta. She's from BLK Super Specialty Hospital.